Greetings and a very warm welcome, everyone. Thank you for joining us, and we're very delighted that so many of you are able to make it. We have over 200 registration, and hopefully a good number of you will be here. I just want to mention upfront that this is a bilingual webinar, and we have French and English interpretation available. And please make sure to make use of the interpretation function at the bottom of your screen and change language channels as you see appropriate. And I just want to introduce myself. My name is Wodla Kidan Amde. I'm a researcher at the University of the Western Cape. I'm very delighted to be opening this webinar. And I just want to acknowledge the many partners who have come together to make today's event possible. The International Development Research Center, IDRC Canada, the African Community of Practice, the University of Western Cape, the Gender Transformation for Africa collaborative cohort, the African Journal of Reproductive Health, the United Nations University International Institute for Global Health. Today's webinar is part of the African Community of Practice webinar series, which I'm sure many of you have been part of. And it marks the official launch of the new IDRC funded supplement in the African Journal of Reproductive Health, featuring 8 peer-reviewed articles produced by the Gender Transformation for Africa cohort, which have been collaborating for the past 3 years. And we're very excited to share our collective learning over this period across Africa as Africans, to support gender transformative approaches for sexual, reproductive, and maternal health. And we're also excited to share our work with a broader audience such as this as part of the African Community of Practice for Gender and Health, and as part of several partnerships that UWC School of Public Health is honored to co-convene. And we're excited to hear from our colleagues, and we welcome reflections, comments, suggestions as we nurture these spaces moving forward. So quick housekeeping reminders, please keep your microphones on mute unless you're making contribution. And the chat box and the Q&A functions are really important. Please have your say, join the conversation. And this session is being recorded, as you may have well noticed, and we'll make the recording available shortly after, the different platforms, UNU, and partners. And we'll try to do our best to bring in you pre-registration questions and the questions and chats that you will be contributing. So please keep them coming. The order of the program we'll start with the welcoming from David, and we'll give an overview of the landscape of the field. We will dive into specific themes featured in the papers, and we have a panel discussion with our distinguished panelists about the way forward. And of course, there will be a space for Q&A session with you, and finally, closing reflections. So without any delay, I'm very pleased to now hand over to David O'Brien, who is a Global Health team leader at International Development Research Center, Canada. Over to you, Brian.
Thank you very much, Walde. Good morning, good afternoon, good evening, everyone. Very pleased to join this webinar and introduce to hear the authors of the supplement and to explore the theme, what does it take to operationalize gender transformative approaches across different African contexts? As Walde mentioned, I'm Dave O'Brien. I'm the team leader in the Global Health Group at the International Development Research Center. I have the pleasure of working with Chaitli, who you'll hear later in this program, She was my colleague who helped design and launch this program. So very pleased of that. For many of you who are not familiar with IDRC, we are part of Canada's foreign affairs and development efforts. Our mandate is to fund and promote research and innovation within and alongside developing regions. We are the proud funder of this cohort of African scholars who embarked on a collective journey over 3 years ago. Our panelists will be sharing their perspectives on the research process, the importance of their findings, and how they were positioned for use. I'm really looking forward to hearing from them, and I realize that I'm the one standing in the process of hearing from you all, so I'm going to keep this really short. But just a little bit about IDRC and a little bit about the importance of this work that this initiative brought to light. We believe in the power of research and evidence, particularly that is locally relevant and championed to address knowledge gaps to improve sexual, reproductive, and maternal well-being for women and girls. We recognize these results are not only dependent on better health systems, but wider social and structural determinants of health. We're a strong proponent and supporter of gender equality, and we recognize how complex, challenging, and labor-intensive, time-consuming a gender-transformative approach to research can be. In many ways, that is what makes this journal supplement so timely and important. The findings are important, and so is the process. Research process is engaging researchers, health system actors, community-based organizations that may challenge or uphold the status quo as part of the journey and how we come to understand the barriers and the openings for change. The collective of researchers, practitioners, and those seeking sexual reproductive health services have been a collaborative learning experience, and that comes out certainly in these articles. Given the state of support for advancing gender equality, sexual reproductive health and rights, this initiative provides, inspiration and lessons for what can be done and how others might follow. The collective has elevated African analysis and perspectives, flagging expertise key to knowledge translation in their context and across the African continent. The individuals and collective contributions we'll hear today set a strong foundation for deeper and broader efforts to strengthen the body of global South-led research. So it's my pleasure now to help set the context and the landscape. I'm going to hand over the floor to Sundari Ravirandran to lead the next section. She is an independent consultant, senior editor of the international journal Sexual and Reproductive Health Matters, founder of the Rural Women's Social Education Center, and a member of the GT4Africa cohort. So over to you.
Thank you, David. And it's my pleasure to introduce to you today the panelists for this first plenary that provides the context within which the research presented in the supplement are located. Our first speaker would be Kefilat Bello, who will provide an overview of the theme and contents of the supplement. Kefi is a researcher at the Center de Research Reproduction, Human and Demography in Benin, and a PhD candidate at the Institute of Tropical Medicine of Antwerp and the KU Leuven in Belgium. The second speaker will be Asha George, who will present key findings from a scoping review of studies on gender-transformative interventions in sexual, reproductive, and maternal health in Africa. Asha is Research Chair in Health Systems, Complexity, and Social Change at the University of the Western Cape, an adjunct professor at Johns Hopkins School of Public Health. The third speaker is Wolde, who has already been introduced, and he will provide insights about who is doing the research, who is supporting it, which settings are covered, and what the implications are. Over to you, Kefi, for your presentation.
Okay, thank you very much, Sundari. If I can just have the slides. Okay, thank you. So, good afternoon, good morning, everyone. This is my pleasure to present to you a work that have been done almost 2 years of staff-to-staff collaboration. And let me start to express my joy and saying that Africa, it's a great continent. And despite all the challenges we can find about what is happening in the continent, we cannot deny that its people are very committed to bring change and really to work for a better future. So thanks to a support from IDRC, we have been able to work together to collaborate, and this collaboration is really something. It's more about research, but it was also about learning together. So we are really, really deeply grateful for IDRC for this flexibility and the support that allowed this collaboration to happen. Next slide. Next slide, please. So this is a work that connected 6 implementing research projects, and these research projects span 7 African countries. So these are projects working in Burkina Faso, the Gambia, Ghana, Malawi, Niger, Nigeria, and South Africa. And rather than working alone as a silos, this project decided to come together and build a collaborative that we proudly called GT4Africa. You can see the logo up on the top of this slide. So gender transformation for Africa. So we had multiple languages, we had different various health system context, but despite all these differences, we were able to work together thanks to a great facilitation from the School of Public Health team in University of Western Cape. And we worked together through a lot of activities that you can see at the right side of this slide. So we had joint webinars, we had a lot of 2 face-to-face meetings, we had member survey, journal reading, journal corner, and this work that we are presenting now is really a fruit of this collaboration, which is the journal supplement in the African Journal of Reproductive Health. So through this collaboration, we were able to share a lot of tools and a lot of learning. Next slide. Next slide, please. And I was saying that we were 6 projects, but and this is quite a small cohort. But despite the fact that this was a small cohort, we were able to engage also many other feminist researchers, academics, and implementers from a lot of African countries. So we were, for instance, this picture you are seeing here is a picture taken during a face-to-face meeting that we called the Feminist Fiesta. And during this fiesta, it was truly a fiesta. This fiesta, we had many African researcher, academics, and implementers, which come together to reflect actually on the work they are doing, but especially what it takes to implement gender transformative approaches in the various African contexts. What are the challenges and what could be the way forward? So this helped us to not only to stay within this cohort, but even beyond the cohort, we could reflect on the shared values and also what we can do better to bring better gender equality in Africa. Next slide. And as I was saying, this supplement really was is a key output, and we are very proud to present it to you. And in this supplement, it starts with this editorial that I am presenting now. But after the editorial, you can find a scoping review that has been led by Asha, which really showed that it took a stock on what is currently going on regarding gender transformative approaching in Africa. And the key finding is that despite that we have more and more knowledge that is shared or is available, there is really a huge a gap in terms of in terms of the process of implementing gender transformation approaches in African context, and also a lot of gaps regarding who is publishing this kind of research. And we could see that the African voice was really was not very present, and hopefully this supplement is really a step toward making our voice more heard. And to make this voice heard, we can see really that we had 6 papers in this journal supplement, and 6 papers represent each project, but we realized that these papers could be could be organized around 3 themes that actually emerge organically. And you have 2 papers, for instance, talking more about co-designing, co-producing health, gender transformative approaches for sexual, maternal, and reproductive health. You have also 2 papers talking of the role of frontline workers when it comes to design and implement gender transformative approaches for adolescent health, for instance. And then you have 2 papers talking of the experiences regarding male engagement. So you will hear more about the papers in this webinar. But I want to finish my address by sharing with you 3 key lessons that emerge. So we were able throughout these 2 years of collaboration to have some lesson in terms of how we can better implement gender transformative approaches. And the first lesson is really about that we knew it maybe, but really this stood very strongly. We realized that gender power relations are really multi-level and multi-dimensional. So it's not just enough to address one level. So for instance, while working with health workers would be really a good entry point to start to work on gender transformative approaches. We cannot just stay at this individual level, but we have to work, for instance, with the community. We have to work with the system. We have to go deeper. And also, while we are tackling individual for instance, knowledge or attitude, we also need to tackle more systemic change. So this is the first lesson that we learned. The second lesson is that it is important when you start working on gender transformative approaches to identify strategic entry points and also try to navigate some political pathway of change that are important. Indeed, we all know that context is important, so we cannot just have blueprint intervention that we will come and implement. And for instance, in contexts that are hostile to gender transformative approaches, we could really try to see how we can find support, for instance, from patriarchal power, while not jeopardizing what the end goal, while not trying to change also our objective. And the last lesson that we learn is that to be able to have sustainable changes, it's important to work over the long term. It's important to have longer time frames. So we are all aware that the limited time frame of projects may not be sufficient. So it's really important to allow for longer time frame. It's important to have better political investment. And we also need to reflect also as researchers on our positionality. So we are researchers, but we are also members or part of the communities we are working with. So it's important to reflect of how we can continue to work with the communities over the long term. And I think all these lessons are shared in this journal supplement. I hope you will enjoy the reading, and I definitely recommend this for you because it will really be a great reading. And let's continue the conversation. Thank you.
Thank you, Kefi. That was a very inspiring beginning talk. Over to you, Asha, to present the scoping review findings.
Thank you. I'm very excited. It's wonderful to see more than 100 participants here. And I'm just going to try cramming a lot of just a few key findings, hopefully that will elicit you to press that link and read, engage with the supplement, and go for the further details. So I'm incredibly lucky to be working with a wonderful team, building on relationships from many years ago and meeting new people across the cohort. So we worked in the team, and I want to acknowledge Tima, who is a postdoc, who also supported the scoping review. We looked at the last 10 years, up until I think it was 2012 to 2022. What has been published in Africa on gender transformative approaches in sexual and reproductive health and rights. We did the search in French also, knowing that there are biases across the continent. And we had a group team process. We have the Prisma diagram, but we just wanted to flash the key messages here. So we saw that in the last 10 years, there were, or at least until 2022, 52 articles on this topic, and they cover a whole range. So that's amazing. There's a real body of work here to celebrate. Now I'm going to present in the next slide some gaps. Where do we need to go next? Okay, so that message gets across. So there's a substantial scholarship, but it's skewed in several ways. One, Walde is going to go over this. It goes without saying, Africa is not just a continent, it's a continent of incredible diversity, and yet it has its own power dynamics within it. It was striking to see how much scholarship comes from South Africa itself, the country that I'm privileged to work in, but also Eastern and Southern Africa. Hardly any articles from West Africa, Northern Africa. So we really have a challenge in scholarship, in solidarity, in working beyond Anglophone countries and getting Francophone, Lusophone. I know these are colonial languages, but really getting a more broader diversity of evidence published. Striking to me was that the concepts, it was great to see that all of them engaged with power, gender transformation, but that almost existed in a bubble separate from, I would say, the political struggles and the development context of Africa. So there was very little mention of intersectionality, justice, and very few people, interestingly, mentioned the word feminist or patriarchy. This is linked also to what were the theories. Many of the articles had implicit program theories. They didn't necessarily mention a theory, but when it did, it was striking to me that Raewyn Connell, who is an incredible scholar, her theory of gender and power, her contributions to this field are immense, was flagged yet again. However, we know the field comes from many multidisciplinary authors, and particularly LMIC authors. I'm Indian. There's so many scholars who have contributed. So it was striking to me that we're not really drawing from the rich histories and scholars and activists from many different contexts who could be contributing to this. Next slide. In terms of topics, it was really striking that there are very really well-funded networks that have really made a difference in making sure there's scholarship on violence against women and HIV. But striking that there wasn't as much in other areas and nothing on some key topics, so that we know gender power relations have a huge role to play. Nothing on abortion, infertility, menstruation, and importantly for our context, in some parts of Africa, nothing on female genital cutting or mutilation. So these are gaps that really we need to address. It was also striking that, I'm going very quickly, but half the articles included both men and women or male and female. It was primarily a binary definition. But there were, when it came to focusing only on one gender, that there were 20 articles that, or more than 20 articles that looked at men only. And it was striking on this topic, there were only 5 that looked at women and girls by themselves and looked at empowerment. So it's really interesting to see the distribution, a lot of attention to young people, which is fantastic. But really striking to us, and it's a very important topic, but almost half had papers were about masculinity, male engagement, and fathering. And there are some really important contributions in this collection, but also some concerns. A lot of the articles reported positive findings, mainly on self-reporting. from male participants of group training initiatives. And we just felt the evidence base should be more inclusive and more rigorous. Next slide. I think this is my last. I have 2 slides more. I'm conscious of time, so I'm going to keep going. So just briefly, what was really striking is how varied were the outcomes. Out of the 52 articles, 27 were interventions, and we did a follow-up analysis of what were the measurements, how were these outcomes assessed, and that's a follow-up article that's under review. It's striking that so few had positive outcomes, and 6 of those 8 studies were based on self-reported data without more triangulation. There's a table that really looked at 14 of the studies had mixed outcomes, and you really understand how complex it is navigating power, how that there are many negotiations and trade-offs happening. Change is not linear, as Kefi said, but also it's negotiated and contested. And I think that table just really testing our assumptions of what does it take to have impact and how you can see change in one. Sometimes there was change amongst the young girls, but not change amongst the young boys. It was very varied, and I'd encourage you to look at that part of the paper. And importantly, there were some studies with negative outcomes and some that really didn't show much impact. And those papers are really important because they really show that sometimes there's a facade of change, and we really need to check our assumptions and have more rigorous work on how do we really prepare ourselves to support more transformative interventions. Next, I think the last slide, or maybe I'm handing over to Walde. Yes, over to Walde. I hope this has caught your attention, and please go to the article, and I'm going to hand over to Walde, who's going to share a few more findings. Thank you.
Thank you, Asha. And then I'll just be presenting the findings, which are extensions of the scoping review that Asha already spoke about, and we just thought it would be interesting to look closely at some of the patterns in terms of the distribution of the papers across the region, which Asha talked about, and how much Southern Africa and Eastern Africa kind of prevail dominantly, with West Africa distant third and little from North and Central Africa, and across language regions as well, Anglophone dominating, little in West Africa and other language regions as well. And you can see the distribution. And South Africa, 17 of the 45 papers that were eligible for final analysis were from South Africa. And if you look at the map on the right, you can see all the studies were situated in Africa, 67.4 outside South Africa, but 1/3 were conducted in South Africa. But in terms of the distribution of the first authors and the last authors, those are more senior roles in terms of authorship status and location, and you can see how much it's skewed against authors based in Africa. Only 33% of the first authors were from the continent, and the rest being predominantly from America, but Europe and Canada featured there as well. And similar patterns for the last authorship role, 1428, about 42% of the last authors were from the continent, predominantly authors from USA, 42.9. So it's a clear imbalance you could see in the distribution of these senior roles and the recognition that comes with these publications. Another thing we looked at was we take into account all the authors participating in these papers. The left hand side graph and there were 264 authors participating, and we looked at their institutional affiliations, and you can see close to 2/3 were based in high income in institutions, and the proportion of African affiliated authors or authors in African affiliated institutions was a minority. And in terms of funding, the graph on the right-hand side, we try to map the different sources for funding for these researches. We were able to identify about 85 funding sources, with some papers not declaring any funding, but the distribution here as well, much of the resource and the funding coming from high-income private and high-income public sources, and under 10% of that funding was originally from Africa. So these discrepancies, we were intrigued, and in that feminist fiesta workshop that we had with experts across the continent, we raised it with them just to be able to unpack what the drivers are for these kind of differences, and if it anyway resonates with their local realities in terms of knowledge production. And these are some of the recommendations that they put forward based on what they consider to be the underlying reasons for these discrepancies. And they talked about drivers at individual, organizational, regional, and national level, in addition to the global imbalances that were raised. And primarily the running theme was the importance of having local ownership and leadership of gender transformative research in this area to be able to have longer term impact. And this sits also at the center of the importance of pushing for more equitable partnerships between global north and global south institutions and researchers, and trying to kind of shift the gaze towards what's important and locally relevant in the continent. Yeah.
Thank you, Bolde. And now that you have all heard the teaser, let me hand over to Asha for the next panel that gives the deep dive into the 6 papers. Thank you.
Thank you so much, Sundri. I know there's so much to share, but we really want to hear from all the colleagues from across the collaboration. So we're going to do their joint presentations on each of the themes, and we're going to start with co-designing and co-producing gender transformative approaches and interventions. There's a lot of assumptions that co-design is a good thing, and it is, but it means tackling power. So what are the tensions involved, and what have been the lessons learned? I'm going to hand over, there's going to be Dr. Chinazome Ekuime. She's a public health physician and health policy researcher with the Health Policy Research Group at the University of Nigeria, and Lauren Wallace, who's a research associate at the Global Strategy Lab at York University, but she helped lead this research in Ghana, where she lived for many years. She just now relocated to Canada, but she was embedded in the Ghana Health Service for a number of years. Over to the two of you, they're going to kick off on this theme. They're going to present briefly, and then we'll have a chance to answer any clarifying questions before we cycle on to the next team. So over to Chinazome and Lauren. Thank you.
Thank you. Thank you, Asha. And thank you, everyone. So Lauren and I will be presenting insights from our papers. So the titles of the two papers are Co-Creating Gender-Transformative Interventions for Adolescent Mental, Sexual, and Reproductive Health Rights, the Influence of Context and Actors on Process and Content in Niger, Ghana, and Burkina Faso. And then from the Nigerian team, we have Applying Community-Based Action Learning in the Provision of Gender Transformative Sexual and Reproductive Health Services in Ebonyi State, Nigeria. And so we want to also acknowledge the different partners and collaborators. Next slide, please. So why was this work done? And I think Asha has already set the tone by explaining, that usually we all think that co-design approaches, co-creation approaches are very important, and we assume that, oh, it will always end well. But then there's a lot of work, a lot of issues that also come with it. So in the context of gender transformative interventions, particularly for young people, and then particularly for something as sensitive as sexual and reproductive health and rights, co-design approaches, co-creation is even very more important because you want to make sure that the stakeholders involved are involved in the creation of the study right from the beginning. And so that's the concept. It's not bringing them at the end or in the middle, but the concept of co-creation is that they are part of it from the very beginning. And so use of these approaches have been limited, especially in this gender transformative intervention. And then even gender transformative interventions themselves have also been limited in our West African context. And then we can see that from the scoping review as well, that there's been very few coming from that axis of Africa. And so that was part of why we did this work, to be able to describe the process. So that papers are describing the process and the outcomes of co-designing and implementing a gender transformative intervention. And then in the context of Nigeria, we used an action learning approach. For the other countries, the Ghana, Niger, and Burkina Faso, in that context, they examine the relationships between the context, the actor positions, and as well as the co-creation process itself. And then in that, they are not just looking at adolescent sexual and reproductive health, we're also applying that into mental health interventions. So I'll just allow Lauren to do the next slide and then tell us some of the lessons learned.
Thank you, Chinazam. Next slide, please. Yes, so I think, as Chinazam has said, our work is very exciting because it's filling part of the gap that Asha and Wilde were talking about in the West African context, that there was little written, but we have added to that literature now. So it was a good process to do a combined slide deck. So we realized that in our I would say in our 4 contexts, because in our case, we had 3 countries, Anglophone and Francophone, which was also unique. And then in addition to Nigeria, we realized there was a lot of similarities between our contexts in which we worked to do co-creation. And so we highlighted them here as part of what we learned, because we realized that in doing co-creation and also in Nigeria's case, using action learning approaches, it's very important to understand the context and the stakeholders when applying gender transformative approaches. And so we realized in both our contexts, both of our projects were also dealing with adolescents. So we realized in both our contexts, young people are not really normally engaged in designing health programs. They are just often recipients of these programs. So we needed to change that in our approach. And then we realized in both our cases, actually, although there's a lot of challenges with sexual reproductive health rights for women and girls, we realized that the programming is directed at women and girls, but it's an issue that has to also engage boys and men. And a lot of times the boys also felt excluded. So in our approaches, we also try to engage both sets of actors. And then in the Ghanaian context, as Chinazom highlighted, we were not only looking at sexual reproductive health, but importantly, its interactions with other concerns in terms of adolescent well-being, like mental health. And we realized there was a lot of important synergies there, for example, between child marriage and issues like depression, etc. And in both our contexts, there was a lot of conservative sociocultural norms around young people's sexual reproductive health and rights. And they tended to be more extreme and harder on women and girls than for boys and men. And we realized there was also conflicts between some of the actors we worked with. In Ghana, for example, we worked with both education stakeholders in the education sector. So actually in Ghana and Niger, we worked with both stakeholders in the education sector as well as health. And we found that there were important conflicts between the programs they were promoting. So in the health sector, they were somewhat more liberal than in the education sector, which posed some challenges when we were trying to engage and figure out how to do co-creation. And in the case of Ghana, there was a kind of I would say Ghana and also Niger and Burkina Faso, there was a kind of mistrust of outside actors who were promoting sexual health education for adolescents. And this stemmed from, in this case, we had to be reflexive and acknowledge that there was a history of policies in this space. And for example, comprehensive sexuality education, and it had been linked in the media and by religious groups with promoting LGBTQI values, which were seen as, antithetic to the concept of the African family. So we had to navigate all these territories very carefully. And in both Chinozom's paper and in our 3-country case study, we also found there were power imbalances between actors like frontline workers and young people. And there could be a misuse of power by the frontline actors in some cases. So these were all the things we had to navigate. So of course, there are differences, but we found some similarities, which we thought would be interesting. Next slide. Next slide. Maybe we're stuck. Okay. Chinazom.
Okay, so what did we learn about gender transformative approach? So one of the key things we learned is it's a very controversial topic in our context, in the West African context, due to our conservative gendered norms. And so because gender transformative approach involves transforming norms, dealing with the power imbalances, roles, behaviors, and these things that are very entrenched. So it actually, to solve them, even though GTA in itself is a wonderful approach, but beyond that, if you bring that approach by itself, some group of researchers, you're most likely going to fail. Some people, just like some of the insights that Lauren already shared, would attack it and think, oh, you people are coming to talk to us about LGBTQ. This is not what we want. This is not our culture. This is wrong. And so you have to bring in a co-creation approach where all stakeholders involved, even community leaders, the young people themselves, everybody is brought together to be able to build trust, and not just build trust, for them to now also own the intervention and own the program. And so in the Nigerian paper, some of the things we learned is that the co-designed action learning helped critical reflection. So it helped the health workers themselves, the community members themselves, because they were doing joint sessions, for them to actually reflect. So it made them identify and brainstorm on the gender transformative strategies that they could actually implement. How are we going to solve these things? We've realized that, oh, these things, we have these deep-seated biases, but how are we going to overcome them? So it brought those biases to their consciousness. And then, of course, the health workers had their own apprehension. So, but then collaborating with the health worker, the collaboration that happened between the health workers and the community leaders was very essential to build trust, because the health workers, some of their complaints were, is this community members that actually attack us. They receive a lot of backlash when they provide services, particularly contraceptive services to young people. So bringing everybody together made them to, have that trust, and then that kind of, they felt they were now being supported by the community to go on with providing services and SRH services to young people. And then, of course, because the approach takes time, so it was time consuming, and it was series of meetings, but then there need to be strategies to avoid participant fatigue, particularly on the side of the healthcare workers, who are also, they are bombarded with a lot of programs, a lot of other interventions ongoing, a lot of data tools they also have to fill, and then their own core work of providing health services in their facilities. So that was quite quite a lot for them. So I'll leave it to Lauren, please, just to provide more insights on the 3 country
Yeah,
case
so
study.
sorry to cut you. So yes, in the case of Ghana, as I mentioned before, it was really important for us before we did co-creation, we found to do stakeholder mapping to understand stakeholders' positions and interests and values so that we took the right approach. And secondly, there was a need to keep engaging stakeholders, which I think Chinazam has already alluded to build their trust. And so not just at the beginning and then at the end, or one or the other, but continuously throughout. And so they felt that we did actually appreciate their inputs and their concerns. And something interesting that came up from the work in Ghana and also Niger was that we used arts-based tools and approaches in our co-creation, like something called rich picture drawing, where we actually asked adolescents to draw. And this actually was very useful because sexual reproductive health is a very sensitive issue. And so it actually allowed them to capture issues in a much more nuanced way, which maybe will be more difficult verbally. And we also continued along with this use of arts-based approaches in our actual intervention, which I'll discuss in a minute. Thank you. Sorry, next slide. Chinazam, do you want to go?
Okay. Okay, so back to me. So what is next? So what are we going to do moving forward? So currently, we have successfully implemented an action learning intervention, and we've done an end-line evaluation. But then analysis of our outcomes, effectiveness, and implementation, some of them are still ongoing. So interestingly, one of the good things that happened during our study was because of the kind of community involvement that the government saw, because we also involved each local government that we worked in, we involved their local governments, what we call like heads of health, like some district health officers. And then, and when they saw like, oh, this is really working, and the community, they're coming out, everybody is involved in this. And so the government decided to also train other health workers in other local governments that we are not working in. So they wanted to train them on this gender transformative approach, how you're going to identify, understand the power imbalances, all the principles, male engagement, female empowerment of women and girls, and all of that. So we did that training with their support. And so we're also working on our manuscripts, and we are currently strengthening our relationships with the sexual and reproductive health and rights stakeholders in the states and also nationally. So by next week, we're having an upcoming policy dialogue with the national and sub-national stakeholders, because we want to, try to encourage scale up and sustainability. We want them to see that this is a good way to approach adolescent sexual and reproductive health services. Over to you, Lauren.
Thank you. So in Ghana and Niger and Burkina Faso, there has been a successful implementation of the intervention, and the intervention selected was theater for development. So we can talk more about that later, but it's also arts-based, kind of following from the previous comments I made about our learnings about the usefulness of arts-based approaches. And it's been conducted with adolescents who are not in school. But right now, the team is also working with in-school stakeholders to test the intervention in schools because it's a different, more structured setting, and to see how it can be adapted. And there's also a facilitator's manual under development to assist with the replication and scale up of the approach taken in the intervention. And then also building on a national stakeholder forum that was conducted as part of the co-creation. And there was a lot of interest in integrating these arts-based approaches into larger adolescent well-being programming for sexual reproductive health and for other adolescent health issues. And so there's a lot of momentum, and the team is continuing to ride on that momentum to see how it can be scaled up and integrated. Thank you. Thank you so much. We're really looking forward to the discussion.
Yeah, thank you. That's our last slide.
Thank you. Thank you, Lauren and Chinazum. I know there's a lot to share. It's great. We have two questions, which are, I think, points of clarification, but also questions that all panelists, I think if you can incorporate in your towards the end of your presentations, that would be good. Barbara Klugman has asked, did you have any preset frameworks on what to explore in terms of gender power relations, gender and sexual and reproductive health, or did you adapt and develop something on your own? So one question about frameworks on how you had planned to assess change, and particularly in gender and sexual and reproductive health. And then I'm summarizing quickly, but Nafisato Diop has a question for all of our colleagues in West Africa that you've probably seen, not in West Africa, but in other regions, increasing number of women covering their heads or wearing hijab in the name of Muslim practice. Did you find research, or did this come up as a topic in your context? What does it mean for the progressive agenda on SRH and rights and bodily autonomy? Did that come up in your work? I don't know if Chinazum and Lauren, whether you have any thoughts on that, and then we will need to quickly cycle to the other panelists, but I just thought I'd pause. And anyone else, I know there's several co-authors here on the online as well.
Okay, so great. For the first question, in the Nigerian context, we apply the Rogers framework. There's a framework that was proposed by Rogers on gender transformative. So those principles in that framework was what we used, and that was their toolkits. We adapted it, and that was what we used in training the healthcare workers. And then for evaluation, like you asked, the framework, okay, thank you, Asha, thanks for helping me with that. Yeah, so the framework we are using is because it was an implementation research, so we are looking at like a hybrid trial, both effectiveness outcomes and implementation outcomes. So we're using the REAIN framework to access intervention. So one of our key effectiveness outcomes is looking at the quality of the adolescent sexual and reproductive health. Yeah, and so that's that work is like still in the works, and hopefully would get that published. Then implementation outcomes, we're looking at a lot of them. Acceptability, especially, is one of our key, like how acceptable is this intervention to our stakeholders. So I think that's that for me. Okay, about the hijab, and one thing about Nigeria is, because we didn't have time, so Nigeria is very complex. So where our intervention was implemented is in the southeastern part of Nigeria, which is predominantly Christian. So we didn't have the issues about people wearing hijab, but it didn't mean, just like we said, because religion is also very key, whether Islam, Christianity. So Christians, they still had an issue with you giving young people contraceptives. So it means you're encouraging promiscuity. So there were other cultural and religious norms that we also faced in the south and southern part of Nigeria. But if we had implemented it in the northern, we would have also faced another backlash from the Muslim community. So Thank you.
Thanks.
Thank you,
I think in the
Chimasomo.
interest of time,
Can you?
I will just type in the chat. Yeah, because we're
Okay,
behind time,
great.
so I'll just
Thank
type
you,
my
Lauren.
responses.
Thank you. And I would encourage others from the collective, if you have thoughts on these two questions, let's start responding in the chat because we are pressed for time. So if we can move forward, thank you, Chimasomo and Lauren, for working together and sharing your insights. There's a lot of rich detail in their papers, so I'd encourage colleagues to go there. And you mentioned part of your work was working with health workers and the biases that happened and how did you engage, build trust. We have two papers that really also worked very closely with the realities of peer educators in South Africa and community health workers in Malawi. And how do they navigate gender norms and what is their role in gender transformative programming? So over to Colleen Wagner. She is from Nkosa, from Nkosa. She's a grant manager. It's an organization that is an umbrella organization supporting networking in HIV and AIDS and communities in Southern Africa, as well as Witness Alfonso. He's a research fellow at the University of Malawi. Welcome. You have 10 minutes for a quick presentation so that we have a chance to hear from any other questions. Thank you.
Thanks, Asha, and thanks, colleagues, for the opportunity to present. So as Asha says, Witness and I are speaking on frontline workers' perspectives in supporting gender transformative approaches to SRHR. And so we'll tag team, I'll do the South African perspective, and then he'll do the Malawian perspective. So the title of the paper was Let's Hear It from the Facilitators, Experiences of Peer Facilitators in Engendering Work with Adolescent Boys and Young Men in Cape Town, South Africa. And so there are the list of authors, and we were a collaborative project. Obviously, we know the funder was the IDRC, and great thanks to them for that. So the School of Public Health at the University of Western Cape was one partner. Nkosa, the organization I work for, we're a civil society organization with a national footprint in South Africa. And then one of the implementing partners in the sub-district we worked with was Hope Africa. That was the third partner in our collaboration. Yeah. Witness, over to you.
All right. Thank you very much, Colin. Thank you very much, everyone who's part of this very exciting platform. Yeah, from Malawi, yes, we had a paper, and the title of our paper was Empowering Community Health Workers in Malawi to deliver gender-responsive life skills training for adolescent mothers to overcome social exclusion. I should mention that this paper is a product of an intervention study that together with our partners from African Population and Health Research Center in Nairobi, but also ISSP in Burkina Faso, we've been implementing in Malawi and Burkina Faso. We just call it a promote a project. I think you can get more information about the project that resulted in this paper from reading the full paper. But I should mention that that's the list of the authors, bringing together partners from APHRC, University of Malawi, Center for Social Research, as well as the ISSP guys. And I think in terms of the partners, I think that's the list. And just to mention that I think the work was funded by IDRC Canada. So maybe Colin, you can go ahead.
Next slide. Thank you. So why was the work done? South Africa faces entrenched inequalities and harmful masculinities shaped by colonial and apartheid legacies within our country. Peer facilitators as frontline facilitators of SRHR-related information and skills building have the potential to implement gender transformative approaches in national SRHR programs. One example we used was a My Journey program, which was implemented by NACOSA. So it was a global funded project within South Africa. The study aimed to explore the lived realities of male peer facilitators and assess how a gender transformative approach can be better integrated into their work. And so we did this with 2 social and behavior change interventions. The one was called One Youth Can, and the one was called Skills Guys. So we used these 2 gender transformation, these 2 programs to see how we could integrate GTA within the spaces that they operated in. Over to you, Witness.
All right. Thank you very much. On our part, I think in Malawi, I should mention that I think teenage pregnancies are one of the challenges that as a country we are grappling with. At the moment, 32% of our adolescents are already pregnant. That's according to the most recent data, and you can see that is a very big problem because we have moved from 29 to 32, which simply shows that I think issues of teenage pregnancies are indeed a big challenge. But at the same time, when these people, when our adolescents become adolescent mothers, access to sexual and reproductive health and rights services is hard for most of these people due to cultural and religious beliefs that are deeply seated, especially among those that are supposed to provide very relevant services to them. So issues of social exclusion of adolescent mothers when it comes to the health and the other services has negative repercussions for them, their children, as well as their families, because we're talking about them being excluded from very important services like health services, but also education, but also lack to exposure to psychosocial support. And this has got lifelong challenges like exposure to poverty, because they cannot go back to school because the environment is not conducive for them. They cannot manage to access very important healthy services, leading to exposure to different health problems. You see, community health workers, in our case, we call them, currently they are called disease control and surveillance assistants. They are the ones that are well placed to respond to the needs of this group, because these are the ones that are responsible for providing preventive and promotive health services to the communities, and they're the ones that are very close to this group. But due to the cultural and the what I can say social norms, they are failing to do that because they have got other attitudes that are preventing them from helping this kind of a group. So this stimulated the discussion or the heart of this paper, as we thought it was important for us to really examine the community health workers' perspectives about an intervention that we had implemented in the course of the project that we were undertaking in Malawi, in trying to strengthen their capacity to facilitate gender-responsive life skills training for the adolescent mothers in Blantyre. Over to you, Colleen.
Thanks, Witness. Next slide, please. Thank you. So what did we learn about GTA? And we shared this over 2 slides. So in South Africa, we're going to speak about contextual challenges, and then we're going to speak about the curriculum and the capacity issues. So with regards to the contextual challenges, we realize that our peer facilitators operate in violent, gang-affected communities, especially the areas that we work in, where trauma and patriarchal norms are the everyday experience of many of our adolescents and young people, with gun shooting, etc. in some of the communities. The lived experiences of peer facilitators with participants both helps build trust, but it also exposes the facilitators to emotional strain, obviously because they're from the same communities. And then the other lessons we learned in the curriculum and capacity issues, the curricula of 2 interventions studied are rigid due to the restrictions by these intellectual property owners, their organizations. So they limit contextual adaptation because these IPOs drafts a program. I said skills guys and One Youth Can, and it's implemented nationally. It's rolled out wherever they do these. So it didn't account for the contextual adaptation, and then potential GTA elements in the curriculum varied widely in implementation, from some being gender blind to others being gender transformative. And Dr. Tanya Jacobs is in the room. They overlaid the GTA framework and then assessed every module and every component of these programs. And then facilitators often felt unprepared, especially on topics like SOGS and addressing homophobia. Thank you. Back to you, witness.
All right, thank you very much. In Malawi, I think what we understand is that adolescent mothers struggle to access quality sexual and reproductive health rights services, mainly due to the attitudes and the judgment from the community health workers coming from the religious but also cultural beliefs. And these community health workers, they receive 12 months training to prepare them to provide the services that they're supposed to provide in their work. However, we see that 12 months training is not adequate to comprehensively address the attitudinal issues and beliefs that may affect the quality of care they provide to their clients. And that's what necessitated us to test employing a GTA approach in trying to deal with the deeply seated beliefs to kind of deal with the information deficit that these community health workers have in terms of trying to to provide the quality care to this kind of a group. So we came up with two interventions, which was one, implementation of the value clarification and attitudes transformation training, which was designed to enhance the community health workers' awareness of sensitive gender, sex, and sexuality topics to allow them to implement the interventions free of judgment and the personal bias. But also we included in that training topics that highlighted the disparities that affect the specific elements of women and adolescent girls in pregnancy and sexuality, so that they should understand why it is very important for them to provide the services without any attitudes, without their judgment, to help this group. And in addition to that, we also implemented a trainer of trainers training, which was aimed at trying to equip the community health workers with practical knowledge and skills to empower their adolescent mothers in their communities to make informed decisions on the different aspects of their life. So, like in Malawi, the intervention targeted the root causes of the gender bias and the discrimination. And the GTA approach encouraged these community health workers to reflect on their own beliefs and attitudes towards gender roles, but also adolescent motherhood, allowing a deeper understanding and commitment to gender equity and equality. And what we've seen is that the GTA as an approach has potential in shifting people's attitudes from judgmental and stigmatizing views to more supportive and understanding attitudes. And we see that employing GTA helped the community health workers to realize their role and change their attitudes towards the adolescent mothers, leading to improved quality of care and support that adolescent mothers receive, creating a more inclusive and equitable environment. We also see that the intervention helped to learn and appreciate the value of including gender transformative elements, especially in the training of community health workers and possibly other actors who interact with adolescents in their line of duty. Over to you, Colleen.
Thanks. And so excellent. Thank you, witness. So again, for South Africa, the other two things we learned about this project was that the facilitator role complexity and internalized masculinity. So around the facilitator role complexity, we realized that these peer facilitators juggle multiple roles. They must be a recruiter, a mentor, a role model, an educator, and they are obviously peers themselves from the communities we work in. They had challenges like time constraints and performance targets because the My Journey program was a target-driven intervention. And then at the same time, they are also trying to deliver these complex topics and hold space for the peers that, or the young boys that they were engaging. And it undermined deep engagement with participants. And then despite challenges, facilitators showed initiative by integrating intersectionality and promoting inclusive discussions. And then on the internalized masculinities, one of the lessons we learned was facilitators themselves grapple with harmful gender norms and must navigate dual identities. So in the sessions and in the lessons, they navigate positive masculinity in the sessions versus the hegemonic masculinity in their communities. And so this was the constant tension for our facilitators on the front line. Over to you, Witness. Thanks.
All right, thank you. So what's next? So based on what we've learned from that study, as we have highlighted in our paper, we see that to combat deep-rooted gender norms and structural injustices, I think there is need for different stakeholders that involved in such sets to consider integrating value clarification and like VCAT workshops, but also even the TOTs in trying to improve the standard of care to adolescent mothers. I think these deeply rooted beliefs, they are not easy to deal with, but I think employing GTA approaches is fundamental. It's proving to be fundamental in trying to provide a change of attitudes, and we think with these results, it is important perhaps to engage with relevant stakeholders and the others that interact or provide services to adolescents for them to appreciate the importance of employing GT approaches like the VCAT, but also even the TOTs. And in terms of future research, I think from what we've learned from our paper, we see that perhaps it would be very important to examine whether similar interventions can be extended to other actors in the health system, but also even to community leaders, parents, and with young people, maybe that would be valuable in informing action to drive a broader social change.
Thank you.
I think in brief, that's what I can say. Yes, over to you.
Thank you so much, Witness. So for South Africa, what's next? Some of the programmatic recommendations would be to invest in sustained context-sensitive capacity strengthening and mentoring of peer facilitators, to recognize facilitators' lived experiences as foundational to gender-transformative approaches, to adapt curricula to local realities and allow flexibility in implementation, to institutionalize supportive policies for debriefing, supervision, and facilitator well-being, because that came up frequently as a challenge, and then to advocate for long-term funding and systemic change to support transformative goals. And then also around future research recommendations, to explore facilitators and participants' perspectives further, and then to investigate how intersectional systems of power shape gender socialization and masculinity. Thank you. I think that was all the slides.
Thank you, Colleen and Witness. It's very hard to present so much in such a short time, but I think you've captured the key elements of how, despite biases community health workers may have, creating spaces for reflection can really surface a lot of where they come from and how they themselves are very good experts of their own working context and how better they can navigate that. And I think the contextual realities in South Africa really spoke to that, but really how we need to support them to be agents of change. It means working with them, but also addressing some of the programmatic barriers. So I am going to encourage colleagues to put questions in the chat in the question and A, and we're going to cycle through the last panel because we are hearing about, we're going to hear from two colleagues about male engagement in maternal health. And I just encourage that if there are questions, we have other team members, that colleagues keep contributing in the chat, in the question and in the Q&A, so that we have time for the overarching reflection at the end. So we have now two very dynamic projects. Dr. Matt Lowe, you've who's the director of the Society for the Study of Women's Health, and Dr. Abdul Nahu, researcher and executive director at GT4Africa. They're really going to reflect on and share some findings on what it meant to work with men on maternal health programs in their context. Over to you.
Et bonjour tout le monde et merci beaucoup Acha. C'est un plaisir pour nous de présenter en français la synthèse de nos travaux. Je rappelle que notre groupe avec Matt et les collègues au niveau de la Gambie, la Société pour l'étude de la santé de la femme et d'autres collègues au niveau de l'Université de Toronto ont travaillé sur la promotion de la participation des maris sur la préparation de l'accouchement et des complications dans le contexte de la Gambie et les implications qu'on peut tirer en termes de transformation de genre. Au Niger, nous avons travaillé avec des collègues, notamment de GT4Africa, qui est le groupe de recherche et d'action pour le développement, mais aussi d'autres partenaires locaux, en l'occurrence l'association des sages-femmes du Niger, mais aussi avec le gouvernement à travers les directions de la santé. Donc, ce que nous avons fait, c'est d'essayer d'examiner comment on peut transformer et intégrer les normes de genre, y compris les pratiques sociales dans la promotion de la santé maternelle grâce à l'engagement des hommes. Je pense que nous allons faire économie de la première slide. On peut partir directement sur la deuxième slide sur pourquoi nous sommes en train de faire ce travail. Slide, please. Pourquoi nous faisons ce travail? Je pense que dans le cas du Niger, ce travail répond à deux défis majeurs. Le premier, c'est la faible utilisation des services de la santé de la mère et de l'enfant, y compris les services de la planification familiale. Et tout simplement parce qu'il y a une faible participation des femmes à la gestion de leur vie reproductive. En 2021, il y a eu une enquête nationale qui a montré que 67% des femmes ne sont pas impliquées dans la gestion de leur vie reproductive. Ça fait quasiment 8 femmes sur 10 pour qui c'est les maris qui décident quand il s'agit de leur question de santé. C'est beaucoup, mais de l'autre côté, nous avons conduit une revue globale de la littérature de l'implication des hommes et il ressort que finalement, les hommes, ils sont associés comme des alliés, c'est-à-dire des gens à qui on fait recours pour aider les femmes ou pour permettre les femmes de prendre certaines décisions. Mais dans le cadre de ce travail, notre objectif, c'est vraiment de réexaminer les modalités de participation des hommes. Comment faire pour aller au-delà de la simple association ou de la simple implication pour responsabiliser vraiment les hommes à identifier et à transformer les normes qui sont gênantes ou qui entravent l'accès des femmes aux services de santé, et y compris les services de la planification familiale. Je vais laisser la parole à Matt. Matt, over to you.
Thank you very much, Nuhu. The presentation that I am going to make today is part of a larger project that was implemented in the Gambia and Ghana. But I'm going to focus mainly on the Gambia component that was aimed at promoting the participation of husbands in activities preparing for birth, but also addressing potential delivery-related complications. The Gambia is a highly patriarchal society, and it has been reported that although men can decide when and where their pregnant wives could seek care, yet there is notably limited participation of men when it comes to issues of pregnancy and childbirth. So what we wanted to do is we wanted to transform the existing gender norms that are limiting men from participating in pregnancy and childbirth by implementing the project in 33 communities in the Gambia. Next. No.
Thank you. Ce que nous avons fait de manière globale dans le contexte du Niger, j'essaie d'abord d'explorer les normes sociales et de constater que finalement, dans le contexte du Niger, l'image de l'homme dominant, de l'homme fort qui assure la prise de décision, qui prend en charge la famille, elle est toujours présente, cette image. Et c'est aussi une image qui est prédominante du fait de non seulement de la religion, mais aussi de la tradition, qui continue à perpétuer les systèmes de domination en matière de prise de pouvoir, en matière d'occupation de l'espace communautaire aussi au niveau social, en matière de gestion des communautés, de gestion de la société. Cependant, lors de nos travaux, il est apparu qu'il y a une certaine marge de manœuvre pour les femmes. Justement, des marges de manœuvre en matière de la décision d'utilisation de méthodes contraceptives. Et de nombreuses études l'ont montré, les femmes arrivent à prendre certaines décisions à l'issue de leur mari. Et, quel que soit le niveau de la domination au niveau social, il y a toujours au niveau individuel des marges de manœuvre où la femme peut prendre certaines décisions à sa guise, mais aussi en matière de pratique de certaines activités génératrices de revenus et surtout en milieu rural, dans la mesure où ces activités n'empiètent pas aux responsabilités traditionnelles pour la femme, puisque la même démarche a montré que la place de la femme pour la plupart des personnes au niveau du milieu rural, c'est toujours à la maison, s'occuper des enfants et de la maison et ainsi de suite. Donc, ce que nous avons fait, c'était de mettre en place des groupes que nous appelons les groupes d'analyse sociale et action. Ce sont des groupes qui permettent aux hommes de réfléchir ensemble, d'identifier les normes qui entravent l'accès aux services de santé pour les femmes et après d'identifier quelles sont les normes qui sont possibles d'être changées au niveau des communautés. Et une fois que ces normes ont été identifiées dans l'ensemble des villages d'intervention, les hommes ont été appelés à concevoir des plans d'action. Et donc, ce sont des plans d'action qui sont autonomes, qui sont rédigés au niveau des communautés et qui ont été mis en œuvre par les hommes. Et c'est toute la spécialité de notre approche de responsabilisation. Plutôt que d'apporter la solution, c'était aux hommes, et y compris des groupes aussi avec les leaders religieux et les leaders communautaires, de réfléchir ensemble, de dire que bon, voici la situation, qu'est-ce que nous pouvons faire et mettre en œuvre ces plans. Et c'est la stratégie globale du projet. Mais bien sûr, en amont, il y a eu une formation pour les hommes pour savoir comment bien utiliser les outils de l'analyse sociale et action. Over to you, Matt.
So to promote the participation of husbands in the activities preparing for birth and potential delivery-related complications in the Gambia, we designed a gender-transformative approach training that was specifically aimed at increasing knowledge and understanding of birth preparedness and complication readiness, but also shifting existing gender norms that are limiting men from participating in pregnancy and childbirth. So the topics that were covered included power relation, gender and power relation, fatherhood for the training of husbands, danger signs of pregnancy for women and for husbands. So these were the topics that were covered in the gender transformative training, with the central objective of increasing knowledge of birth preparedness and complication readiness among women and their husbands, but also in a bid to shift existing gender norms and patriarchal notions that are limiting men from participating in pregnancy and childbirth. Nuhu?
Voilà, merci. Les leçons que nous avons apprises, je pense qu'on peut citer principalement trois leçons apprises. La première des leçons, c'est l'importance de la dynamique de groupe. S'il faut transformer les pratiques sociales et inverser les rapports de genre, il faut obligatoirement une dynamique de groupe parce qu'en général, ce sont des pratiques et des normes qui sont valables au niveau communautaire et non au niveau individuel. Et donc, la dynamique de créer des groupes de hommes et des leaders qui réfléchissent ensemble a permis vraiment de faciliter l'évolution des rôles masculins et de permettre une liberté et une participation accrue des femmes pour l'accès aux services de santé. Et la deuxième leçon, c'est d'abord que la responsabilisation est naturellement meilleure qu'une implication. Il y a toujours une différence. En anglais, les termes engagement, empowerment ont des connotations différentes. Mais par responsabilisation, nous entendons de donner aux hommes les moyens de penser et d'agir librement, de mettre en valeur leurs apprentissages, leur savoir-faire de leur communauté pour déclencher une transformation durable des rapports de genre. Et la responsabilisation peut être une porte d'entrée si on cherche à changer de manière durable les normes sociales. Et la troisième leçon, c'est l'importance des leaders communautaires. En général, les changements sociaux, ils arrivent soit par apprentissage social, soit par l'influence sociale. Et en mettant les leaders communautaires en avant, on a une grande impulsion de l'influence sociale, c'est-à-dire les hommes qui sont vus comme des modèles quand ils agissent, on a beaucoup plus de chances aussi de mobiliser les autres hommes au niveau des villages et globalement au niveau de la société, mais aussi en termes d'apprentissage social, de travailler avec les hommes qui ont un certain niveau de pouvoir. Ils sont les plus aptes à déclencher cette transformation, on va dire plus globale au niveau de la société, mais le temps nous dira quelle sera la durabilité de cette transformation. Une chose, c'est l'échelle, mais une chose, c'est aussi la durabilité. Voilà, over to you, Matt. A slide, please.
So what we have learned in the case of the Gambia is that although gender transformative approach training could be an effective model for shifting gender norms that are limiting men from participating in pregnancy and childbirth, we also have to be cognizant of the fact that the factors that may limit men or husbands from participating in activities pertaining to pregnancy and childbirth go beyond the training sessions. For example, it was evident that the competing social responsibility of husbands contributed or constituted a major factor that could limit their participation even in during the training. And there are also other related social responsibilities that are really conflicting with the assigned gender responsibilities of husbands. So any gender transformative training program that has been designed or that is being implemented to shift or to promote the engagement of husbands in maternal health issues should be careful of the conflicting social responsibility of men. So you also need to be careful of how to strike a balance between promoting male also while respecting the autonomy of women. Because it was evident, although we may want to be shifting gender norms so that men could participate in pregnancy and childbirth, but we found out that not all women perceive the participation of men. For certain women, they believe that having men participate in issues related to pregnancy and childbirth would mean giving them more, when actually your objective is to promote or to empower women related to pregnancy and childbirth. So these are some of the lessons that we have learned. And, you know, we are currently trying to see how best we can use the lessons that we have learned from the gender transformative training to possibly scale up the project intervention package to other Gambian communities with similar patriarchal norms and gender-related issues. So just to add that before Nuri comes in, just to add that as part of the next step that we're taking, we also are currently working with the community health intervention for improved prenatal mental health care in the Gambia through musical engagement. What we are trying to do is we are trying to use the lessons that we have learned in our gender transformative approach training to also work with the community health intervention for maternal mental health through musical engagement to see how best we can use gender transformative approaches and also participatory music making to promote maternal mental health in the Gambia with a particular focus on the participation of husbands. Thank you. Nuru, next.
Thank you, Matt. Pour les prochaines étapes dans le cas du Niger, je rappelle que grâce à ce soutien de CRDI, nous avons travaillé dans 24 centres de santé. Nous avons visité 24 communautés dans lesquelles nous avons mis en place des groupes de réflexion et d'action qui fonctionnent. Je pense qu'en termes de prochaine étape, c'est de pouvoir suivre et promouvoir la dynamique des groupes de réflexion, de voir jusqu'où la sustainabilité ou on va dire la durabilité de ces groupes d'intervention qui vont travailler et comment ça peut se maintenir de manière indépendante au niveau des communautés. Je pense que cet aspect de durabilité, c'est assez important quand on parle des approches transformatrices de genre. Les approches les plus réussies sont celles qui sont capables de continuer à perdurer au-delà de notre période d'intervention. Et le deuxième point, c'est de promouvoir l'approche par le couple. La question de la santé reproductive, jusqu'à présent, on a travaillé avec les hommes sur l'importance d'accompagner les femmes, de leur accorder le droit de les accompagner vers les services de santé. Mais comment promouvoir cette dynamique de couple de sorte que les hommes aussi peuvent être impliqués, non pas en tant qu'accompagnateurs ou bien des gens qui permettent aux femmes d'accéder, mais aussi en tant que bénéficiaires de services de santé de la reproduction. Puisque finalement, quand on regarde les responsabilités en termes d'accouchement, de la prise en charge de l'enfant, les hommes aussi ont une grande responsabilité et les coûts aussi sont engagés de la même manière, peut-être même de manière déséquilibrée quand ça arrive à la prise en charge de la grossesse. Donc, je pense que ça, c'est une manière de voir. Il y a déjà des expériences en cours sur les écoles de couple où les questions de la santé fondamentalement doivent être discutées entre le mari et la femme de manière conjointe. Et je pense que ça peut améliorer cette idée de responsabilisation et de transformation des équilibres de genre que nous promouvons. Voilà, je pense que c'est globalement ce que nous tenons à partager. Merci beaucoup.
Merci beaucoup, Abdul et Matt. I know c'est très difficile parler sur tous les détails, but I think it was really valuable to reflect on the change. We're going to ask colleagues, there are a few questions in the chat. We're going to ask colleagues to put responses in the chat and the Q&A to keep that alive, but we're going to transition to hear from other colleagues who are going to speak about this from their own perspective. So I'm going to hand over to Joanna, and then after the panel, Joanna's going to hand over to Tanya to close at the end. Thank you very much, and look forward to hearing from Joanna and the next panelists and staying in touch.
Thank you very much, Asha. I'm Joanna Riha, the research lead for gender equality and intersectionality at UNU IIGH, and it's a real pleasure to be co-hosting this webinar and launch. And I think before I swiftly transition into the panel that I'm leading, I just wanted everyone to take a minute or a few seconds to really recognize the immense amount of work that has gone in to the supplements, to the research that informed the supplements and papers within them. I think, it's a tremendous amount of work, so rich and so much that we'd love to spend more time discussing and hearing from authors, about. We will have to pause and slightly pivot. And I have the honor of chairing a panel session now with 4 fantastic experts who I will introduce in a minute. And the idea is to really look at what next and moving forward with some of the evidence, with some of the lessons that have come out of the papers. So we're looking at it from different perspectives, as Asha said. So on the panel today, we have Friday Okonofua, who's the Professor Emeritus in Obstetrics and Gynecology and Reproductive Health at the University of Benin. And Friday was also the founder of the African Journal of Reproductive Health back in 1997, if I'm not wrong. We also have Stella Bosire, Executive Director of the Africa Center for Health Systems and Gender Justice with us today. We have Chetali Sinha, who's the Senior Program Specialist with a Global Health Division at IDRC and has been, a great champion and supporter of a lot of the work that you're seeing presented today, but the gender portfolio as well. And Faith Nfi, Senior Program Coordinator for the Executive Programs at the Africa Center for Disease Control and Prevention. So Africa CDC, as some of you may know it. In the interest of time, we have a really tight 20 minutes. We've cut down, in terms of Q&A responding. So I'm going to try and collapse perhaps some of the questions I had originally planned, and maybe focus on 2 main ones and invite all panelists to share their views. And I think the first, we've heard a lot about, where scholarship lies on gender transformative research on the continent, but how do we better support African engaged scholarship on some of the issues we've heard about today, but particularly looking at the more gender transformative pieces, but also linked to how do we support scholarship is how do we do that in terms of donor commitments and funding. So maybe I can turn to each of you to share a couple of minutes in terms of your reflections, perhaps what more we can do from your perspective to address some of the gaps that we've heard about, some of the next steps that we need to move towards, both in terms of scholarship, but also in terms of donor commitments. Friday, can I start with you, please?
Yeah, thank you very much. I'm indeed very pleased to be here and to be engaged in this panel, and on a very important topic that as a journal, we've been trying to grapple with the deficit of relevant evidence for doing gender transformative work in the African continent. And I would say that scholarship in this area is still in its infancy, very primordial stage in the sub-Saharan Africa. As I've said, it's particularly worse in North and West African regions, as has been said in this conference. Because of lack of time, I would like to summarize what I would call how do we build scholarship for gender transformative work in Africa. I'll summarize them as follows. The first is mentorship. We need what I read from everything that papers from in your group was that there's so many of you who are so knowledgeable about these issues. And I asked myself, why can't these people form up a network of mentors working on this issue? Second issue is research training, because even with the mentorship program, we still require proper training in methodology for including gender perspectives into various forms of research in Africa. So this is important not only for doing the research itself, but also for publishing in journals. And thirdly, funding and grants are needed, especially through dedicated and collaborative research grants dedicated to this issue. And I'm very grateful and happy and thank the IDRC for funding this particular initiative. And thirdly, the research networks and partnerships so that you can work together. And this is what we've done. And it has worked extremely well in this issue. And then knowledge dissemination and impact. I think this is the first time the journal is publishing a supplement of this kind. And we were very enthusiastic to publish it because we realized that, you know, in all of the publications we had over the years, this is one of the first time we're having this dedicated publication related to gender transformation. Now, of course, policy briefs. I do hope that at the end of this project, you'll be able to do some policy briefs that will bring the issue not only to researchers themselves, but also to policymakers and funders who will be interested in funding this area. And then finally, institutional support and incentives should be given. We should have not only institutional support, but I will call policy commitment, political commitment by governments, because this is an unmet area of research. And it's also very important for development. To that extent, I think that political will from policymakers and institutional support from institutions will be very relevant, and incentives as well. So thank you very much. I'll stop so that others can have the time to talk, opportunity to talk as well. Thank you.
Thank you so much, Friday. And I think you gave a very nice, succinct list. Stella, can I turn to you? What do you think could be done to better support scholarship, also from the perspective in terms of donors? But please.
Not to repeat what Prof has said. First and foremost is there has to be a different way of doing things in terms of the kind of support that is being, the kind of funding that is coming into the continent to support the work. We do not live single lives. Women and girls in this continent don't live single lives. And so there has to be an appreciation around the intersectional approach to this work. And that means that funding long-term and funding multiple variables that are being looked at, that really, if you look at how they triangulate in terms of connecting, is something very important. The second thing that I want to, and perhaps I could use this opportunity to share one of the tools that the center has developed, which is a scorecard, to be able to see how can we increase investments in women's research, health research in development. And part of it is that it's a tool that we're going to use in academia, we're going to use in private sector like the pharmaceutical, is to ask if you're to look how much money still continues to be invested. And this is the place where we say action to research. Yes, we identify the problems, but are we ready to put in the money to be able to develop the solutions? And so there has to be a meaningful way of tracking. How do we track and ensure that the resources that are being put, that we continuously nuance a couple of things that are missing, like the gaps that have come out in this conversation. The other third thing is centering research within communities. We, as researchers, one of the things that we have to appreciate is indigenous communities have knowledge. Indigenous communities have had their own ways of understanding the problems. How then do we bring the expertise, which is formal scholarship, and connect it to community-based knowledge that exists, and tap into that to be able to reinforce the products that we release from the research. Finally, I think the most important thing, and I want to reiterate what Prof has said, is that, Joanna, this cannot be the last time that we meet. Can we find another way of connecting each other? Can we find, I work in the East African region and Central Africa. Is it possible to be able to connect each other with the work that you're doing, with the materials, be it published and unpublished work that we can learn from each other? I think if we can have a hub like that one of practitioners that constantly meet and share best practices, I think we'll be able to move ahead in responding to reproductive health and maternal care. Thank you.
Thanks so much, Stella. And I think, that was very much the vision for the African Community of Practice on Gender and Health. And, we can do more to better connect and build. But I really liked your point, published and unpublished research. It's, we're focusing again a lot on published research for a reason, but recognizing that there's a lot of evidence and learning experiential lessons that are not published, and how can we draw on that as well? So I think that's a really critical point in addition to the various other ones you've raised. In the interest of time, can I turn to Chetali? And Chetali, similar questions, but maybe perhaps on this point about the need for long-term funding. If we're talking about, gender transformative interventions, it's about power relations, it's about long-term social change at different levels, which is really hard to do. From a donor's perspective, perhaps, and I'm putting you a little bit on the spot, but, in terms of longer term funding, how do you think that could be moved forward, let's say, from the donor's perspective?
Sure. Well, let me just start by saying how humbled and honored I am to hear from all of the researchers and all the great work that they're doing. It's really wonderful. So thank you to all of them. And also to have Friday, who's the founding editor of an African-based journal where this is published. I think this is just a wonderful culmination of a lot of work. So that's great. So to answer your question, I think that what's needed, I'm going to maybe just touch briefly upon the scholarship because I really love the points that Friday and Stella mentioned. So if I can build on their points about mentorship and a hub, I think we do need to move beyond. And I think, Joanna, this does get to your question too about longer term funding. I think we do need to move beyond the individual project model and think more about systemic, supportive, and sustainable ways to fund this type of work, because we know that in order for the scholarship to thrive, it's not only supporting the ecosystem of researchers, that's very important, but it's the broader ecosystem, because for gender transformative research to have meaning, you need to work with all of the actors and all of the levels that we've heard about so eloquently from the others. It's about the communities, it's about the institutions, it's about the policymakers at all levels. So I think that sort of systemic approach and supportive approach, which I think that this cohort had in spades, there was just so much peer learning and peer support and mentorship that it embodied. I think that is where we need to go. And we know that we need now more than ever targeted, timely, and tailored evidence. So I think we also need to build on what's been done before, build on what other people are doing. We have to weave together the successes, the lessons, the failures, and move forward together. And I think if I can just say that this partnership with UNU IIGH and hosting this webinar, I think is a testament to that sort of shared value and collaboration. So there are these common goals and common objectives. And I think this is the way, as a donor, we also need to think and invest. It's not just about having siloed projects or siloed investments. It's about thinking about, why are we funding this research? What is the overall goal? It's about moving everybody forward. And that means as donors, we need to look across, we need to think ahead, and we need to be strategic and systemic in our approach.
Thanks, Chetali. And I know it's a lot to pack in, and there's a lot more we'd like to talk about. Faith, can I turn to you before we move on to our last question? From your perspective, Africa CDC, if we think about, at the very beginning of the webinar, we heard about proportion of funding that's, proportion of funding for this work that's from African donors. What more, again, can be done to create space to encourage more investments from Africans on these issues to help advance us as a collective on the continent?
Thank you. Thank you so much, Joanna, for having me. Very thrilled to be here and to be part of this journal supplement launch today, and extremely happy to hear of the immense work and research that have come out of this. I think you hit it right there on the head. The donor collective is one place that we could definitely look at, but beyond that, I believe in the institutionalization of this work, and I think Prof. Friday alluded to that already. When we give it that systemic foundation, it reduces the challenges of finding donors and pushing the interest of donors. The African Donor Collective is there, which I think is one important part to tap into. But can we then look at strengthening our collaboration with the African Union, especially linking this work and making it serve as the evidence base for the work that is done between the within the AU Gender, Youth and Women department. For example, having the evidence that we've created from this work put together, shared with the Specialized Technical Committee on Women, Health and Gender, getting buy-in from these countries, because essentially the AU is funded by member states. But when countries begin to see the value, and seeing the value means this evidence is readily available to them, for them to tap in and for them to see. And that means it's an important point coming back to us to address the issues of invisibility, right? So much has come out from this work, but how are we talking about it? How are we publicizing it? How are we putting it in front of decision makers and public policy makers? I believe those are the key ways that we're able to bridge the knowledge translation gap, so that the evidence that have been brought out of this work is easily translated to the languages and lingua that can be understood very quickly by decision makers and policy makers. And I think this is something that you and I can touch base after now. How do we package this work and present it in a way that presents extreme value, more like a value proposition to donors, to ensure that people are able to see the importance of gender transformation and how this is interwoven into the health system, because it remains at its very core. So I'll stop there for now, but happy to contribute further.
Thanks so much, Faith. Maybe I can stick with you as we transition onto the final question. I know we only have 5 more minutes, but I wanted to ask before we close, in terms of relationships and building stronger relationships between implementers, practitioners, but social movements, and especially now, you know, in the current context with so much pushback, solidarity, and more collective action is needed. What can we do to strengthen perhaps some of those ties and build more bridges?
Okay, thanks, Joanna, for that question. Again, I think it links back to my earlier point around showcasing the evidence, right? People wouldn't believe until they see, and seeing means understanding the different evidence that have come out from the different contexts. I mean, across Africa, right? The issues are not exactly 100% the same, but they're relatable across the continent. Putting the evidence in front, I'll give you an example. One of the things I do at Africa CDC is supporting ministers of health in terms of building the execution capacity. I think a topic like this, weaving gender transformation into the key discourses of health, when these policymakers meet, could be one important way of doing that, and targeting partners whose interests lie very heavily on gender transformation, working with them and leveraging on their voice and their networks would be great. But drawing up an entire partnership strategy, I guess a stakeholder strategy, and getting everyone to the table would be a very great way to start. I know it's not easy to do that, but I'm definitely hopeful that it can be done.
Thanks so much, Faith. Friday, can I turn to you in terms of your views on collective action and solidarity across, particularly with social movements?
Yeah, I think that's very important. I think the first thing to have collaborative partnerships, because that includes respect, it includes trust, as well as the development of shared transformational vision and mission goals. Because it's important that we work together, all of us having the same vision. Otherwise, we'll be working in dispassionate ways, and that will not be very good. And it also includes empowerment and capacity building of team members, so that we'll come to the same table in terms of how we approach these issues, and particularly inclusive and participatory approaches to research, to partnership, to advocacy, to all the type of work we do. Because with participation of all key holders, and don't forget the community participation, because most of the time when we talk about gender transformative approaches, we have barriers, and these are barriers often emanate from community issues. So it's important that we involve community members, stakeholders in the co-design of whatever we are doing. And you know, I've seen a number of approaches where it was possible to change community members from their own perception, from one perception to the other, based on proper engagement with community members. I think that is very important. And advocacy is also very important, including activism. By the way, I'm a feminist, so when it comes to issues of women, I join women to advocate and to push for action in certain areas. And therefore, I don't think that when you talk about feminism or advocacy and on issues related to gender and all that men should be excluded. There are very positive men who can work with you in very positive ways. And then accountability, transparency, and feedback mechanisms is extremely important. And finally, as somebody was talking about long-term commitment to programming and funding, we build institutions only through long-term commitment to such institutions. We have a great institution and partnership currently working. I think donors should be able to commit themselves to long-term support in order to make sure that these issues are deepened very well in the African continent. I will stop there because of time. Thank you.
Thank you so much. I know we have technically 1 more minute left, but I would like to invite our last 2 panelists to speak and give their views before I hand over for closing remarks. So we will run a little bit late, 5 minutes at most. And I hope that's okay with everyone joining us today. Chetali, can I turn to you?
Yes, of course, Joanna. I mean, my other panelists have already shared so many great ideas. I think I would just reiterate what they've said and say that getting the research published is a huge accomplishment, but it's almost like the work is just beginning in a lot of ways. It's about socializing the results and not getting discouraged when things don't happen right away. I think we need to be strategic, we need to be persistent, and we need to be collaborative to make sure that all of this hard work and all of the evidence sees the light of day and leads to some transformative changes.
Thanks, Chetali. And Stella, I'll give you the last word.
I don't know why Chetali has removed the words from my mouth exactly as is. And so allow me not to take, like literally exactly as I intended to. So let me allow the last speaker, Faith, to share her thoughts here.
Okay.
Thank you. Sorry,
Tanya.
Stella, thanks for giving me the floor. I think persistency and pushing, we keep pushing, we stay pushing, we keep breaking those silos, and we keep ensuring that this evidence comes to light. That's it.
Thanks so much, Faith. And I think on that note, our panel session will close. And I'll now hand over to Tanya Jacobs, who's an independent consultant doing work on gender-based violence prevention in health systems and policy, to close. Tanya, over to you. And thank you so much to panelists.
Yeah, thank you, everybody. What an incredible time we have spent together. What an incredible time to learn about this body of knowledge, of research done by scholars from the continent. But as many of you have said, the work is just beginning. There's a call for action, more research, more collaboration, more conversations. We need more time together. But in the interest of time, on behalf of the GT4Africa and the UNU team, I want to thank the presenters, the panelists, the participants, our donor IDRC, for an incredible afternoon of inspiration and a call to action. I encourage you to read further, to have conversations in your professional and personal spaces, and for us to continue to work together. Thank you so much. Stay strong, stay safe. Bye.
Have a lovely afternoon and stay in touch.
Thank you, everybody.
Thank you.
Bye.
Thank you, everyone. Bye.